Hello, everyone. Welcome to our Friday Grand Rounds series. It's good to see all your names. And Dr. Abbott, thank you so much for being here today. It is an honor to get to introduce you to everybody. So let me go ahead and get started so I don't take up your time. Dr. Chris Abbott attended medical school at Texas A&M and psychiatric residency and geriatric psychiatry fellowship at the University of New Mexico. He received research training with the UNM CTSC Master of Science in Clinical Research, UNM KL2 Career Development Award, and the Mind Research Network Center for Biomedical Research Excellence. He is the chief of UNM Neuromodulation and Geriatric Psychiatry Divisions and UNM ECT-Medical Director. He is the PI for several NIMH projects focused on ECT, electric field modeling, and clinical outcome biomarkers. It is our great fortune that Dr. Abbott is on our faculty and that he is here to speak to us today. So, Chris, I hand you the baton.
Thank you, Dr. Katzman. I appreciate the introduction and pleasure to be here. Let me get my slides oriented. Here we go. Okay. Title of the presentation today is ECT Amplitude, Hippocampal Engagement in Clinical Outcomes. And this, some of this data I'm going to be presenting is from the Global ECT MRI Collaboration. We are a member of this worldwide initiative, and ECT research is actually quite challenging to do. And one of the shortcomings is, of course, sample size. And this is our work around essentially everybody submitting data to this worldwide collaboration. And so that's what the Geriatric Global ECT MRI Collaboration is. Disclosures, Dr. Katzman already talked about some of the grant funding. I have no other disclosures to report. Learning objectives for today. We're really going to be introducing this construct called the electric field, and it's analogous to pharmacokinetics. We'll kind of use the term electrokinetics. In other words, when we put a constant current outside the skull, what is the actual dose that the brain receives? And we'll be able to talk about anatomic variability and how that impacts the E-field dose. We'll describe the relationship between electric field strength, neuroplasticity, and antidepressant, as well as cognitive outcomes. And then we'll propose two solutions to individualize the optimal ECT dose. ECT, I know I'm speaking to the choir, is our best treatment. Effect size is relative to pharmacotherapy around 0.8. And this is a synthesis of data with many, many studies. You can't even do an ECT placebo study anymore. It's unethical. And it never gets old watching somebody respond to the treatment and really the resolution of a severe depressed episode, treatment-resistant psychosis to the point that maybe we get to remission, the patient returns to their former level of functioning, starts working again, et cetera, is very, very rewarding and never gets old. The idea with this research, though, is not to make ECT better. We want to understand, of course, how it works, how the brain changes in this very short 4-week window of time. Again, with those that traumatic recovery that we often see. But we really want to mitigate some of the trial and error approach. And I'll be introducing some of the ECT parameter selection decisions that we make as ECT clinicians. But unfortunately, not just here at UNM, but around the world, people do a trial and error approach. We start with a focal stimulation. If that doesn't work, then we progress to a non-focal stimulation, always wrestling with this balance between antidepressant efficacy as well as cognitive impairment. And so that's really getting into the overall direction that we're heading towards. The ECT-mediated neurocognitive impairment, it comes up in our ECT consultations. This is a very real problem on our service. And I do want to acknowledge a lot of our ECT research predecessors here. The field has come a long way in the last 20 years. We do things like ultra brief pulse width. We are better about recognizing the optimal indication for ECT and so forth. But despite that, a lot of our ECT patients do report a lot of subjective and demonstrate objective cognitive deficits at the tail end of the ECT series. This is typically manifested with memory, and this is a summary of 45 pre-post neuropsychological studies. Maria Simkoska was the lead author here, and what I have in the red box are the effect sizes. A large effect size is 0.8, and you can see on the blue box, the word list delayed recall, we have a very large effect size, 1.12. And the translational impact of this is illustrated by a subject who described watching a movie on Thursday night they had previously watched on Tuesday and had no recollection of watching that movie. This was at the very tail end of an ECT series, and they were able to have some levity and kind of discussing this example. They're doing a lot better, the depression had resolved, and so forth. But sometimes the impact of the ECT cognitive impairment does prolong recovery times. What I also want to emphasize, and we'll be discussing during this presentation, is the construct of fluency, both semantic and letter fluency. Letter fluency is how many words that begin with the letter F can you name in 1 minute. And it's a frontal temporal dependent function. Semantic fluency, the example would be animals at a zoo, list items at a grocery store, and more of a temporally dependent function, but still getting a little bit of frontal function. There may be some specificity regarding our ECT parameters regarding the type of cognitive deficit, but we're really going to be focused on letter fluency throughout this presentation. The reason that cognitive impairment is important is that it can be dissuasive, both with somebody that is contemplating starting ECT, or in the example of having done ECT and their memory of the procedure is one about prolonged recovery, and they relapse or have a reoccurrence months or years later, they may be reluctant to rejoin the ECT, restart an ECT series, even though it was effective. This is really illustrated by a former patient. Her friend gave me a letter after she died by suicide. She was an ECT responder, and the content of the letter describes the paradox of the decision that she had to make as she relapsed months after responding. And it was essentially acknowledging benefit. The depression went away, but she had actually a months-long recovery before she could resume her professional roles, professional work-related roles. And she, of course, opted not to come back for what we call a rescue series at that point. And so I can't emphasize enough how important it is to understand and minimize the cognitive risk. The cognitive risk is not necessary for successful response to ECT. And it's important to recognize that disassociation, that if we could do our parameter selection optimally, we could achieve either antidepressant response or response to psychosis, anti-mania, et cetera, while not inducing cognitive impairment. I do believe that goal is attainable. The research and our clinical experience both suggest that it's possible. The first decision we make as an ECT clinician during the consultation is the choice of electrode placement. And I put the 3 commonly used electrode placements here as an illustration. The middle column is a depiction about where the ECT stimulation handles go. And bitemporal is the oldest and most classic form of electrode placement. This is essentially unchanged from the early 1940s. And it's essentially a whole brain stimulation. This is our most effective form of ECT, but it's also associated with the highest degree of cognitive risk. Bifrontal is a little bit more of an anterior placement, and you get more of a frontal stimulation. This is a spherical head model. And what we're depicting here are the placement of the ECT stimulation handles. And the colors represent the degree of neuronal stimulation. Anything red is way above a threshold for neuronal stimulation. And the cooler colors are going to be below a neuronal threshold for stimulation. Right unilateral has been around since the early 1970s, and it's essentially right lateral of vertex and then right at the temporal window, very analogous to the bitemporal. And we get more of a focal type of stimulation. On our service, if acuity permits the occasion, we start with a right unilateral electrode placement, stimulate the non-dominant hemisphere, and we have typically a bitemporal contingency. So in other words, we give it 2 weeks. We see if there is evidence of improvement, and if not, then we go to bitemporal. We made the decision not to use bifrontal. The data suggesting the difference between bifrontal and right unilateral is pretty minimal. So a way to simplify our algorithm is just to start with right unilateral as our non-focal placement. For a left-handed individual, it gets a little bit more complicated. We actually have to determine cerebral dominance. I won't get into the details, but essentially amounts to both a left and a right-sided stimulation with timing post-ECT recovery. Non-dominant hemisphere will be associated with the faster recovery time period. The other parameters are pulse width, and then what we want to pulse number, and this is a construct of both frequency and pulse train duration. The ECT stimulation current is an alternating current. It's both positive and negative, depicted here by the alternating square waves. The amplitude is essentially the y-axis here, or the height of these triangles. Pulse width, or the amount of time the actual stimulation is applied, is the width. The recent development that's been happening over the last 20 years is this construct of 0.3 or ultra brief pulse width. And that is definitely the most cognitively safe form of ECT. The longer pulse widths, that's familiar trade-off. Yes, they are more effective, but they also carry additional cognitive risk. So the way we do the first treatment is a seizure titration. And the method of seizure titration is by pulse number. In other words, we increase first the pulse train duration, which is illustrated here on this y-axis. And then when we max out what the device allows us to do, it's 8 seconds, then we start increasing the frequency. What this amounts to, though, is essentially increasing the number of pulses, almost a pulse doubling with each stimulation until the patient has a seizure. And that is the charge that we determine their seizure threshold at. Just to further illustrate what this figure, the y-axis here, or the height, again, is amplitude, which is essentially constant. Our method with our traditional ECT devices is 800 milliamps. Here we have the representative right unilateral electric field. And I'm using the example in this figure just conceptually to illustrate excessive stimulation. In other words, the whole entire brain is almost above a neuronal threshold for firing. And that, of course, is going to be maybe effective, but also associated with cognitive risk. After that first treatment with seizure titration, we go 6 times seizure threshold. Again, this is all by pulse number. So if the subject took 20 pulses to have a seizure, the next treatment we do 120 pulses. And this research is all from Harold Sackheim, beginning in 1987. These were very large clinical trials. And the first trial with right unilateral ultra-brief pulse width back in 1987 had a very abysmal 17% response rate. So this is despite inducing seizures. So if you do right unilateral at seizure threshold and do not increase the charge or the number of pulses, you will introduce ineffective ECT despite having a seizure. And my point in emphasizing this is that we do recognize the importance of seizure, but clearly there is more to the therapeutic components of ECT than just a seizure. There are chemical agents that also induced seizures that have antidepressant properties. This went out of favor in the early 1950s. But seizure is one component, and I argue that the electric field is the other component. And to disentangle that is going to be essentially what we're getting towards with our research. In 93, we went 2.5 times seizure threshold and had a nice dose-response relationship, bumped it from 17 to 43%. And then in 2000, we went 6 times seizure threshold to get a 65% response rate, which was essentially equivalent to the bitemporal comparator group. The important aspect of this research is that we don't have an understanding from a scientific basis about why there's this disassociation with pulse number and response while holding seizure constant. And that's a challenge because sometimes we get maxed out. Sometimes people are at the upper limit of what the device can deliver as far as pulse number, and we cannot increase it to 6 times seizure threshold. The amplitude, I've already alluded to the fact that it's fixed. One commercially available ECT device, Thymatron, does not allow you to adjust. It comes set at 900 milliamps. This does not allow the clinician to adjust the ECT amplitude. We use a MECTA, and it has an amplitude range between 5 and 900, but the dose titration tables and instructions on what to do are all based on 800 milliamps. And the field has really settled on either 8 or 900 milliamps, depending on what device you're using. There were some recent case reports that came out within the last 5, or in this case, 10 years, where it is possible to induce seizure and actually maybe get the beginning of an antidepressant response at very low amplitudes. Again, the device goes down to 500, so folks were going down to 500, and sure enough, they were able to induce a seizure. Other forms of neuromodulation, transdirect current stimulation, deep brain stimulation as well, recognize the importance of amplitude and make those necessary adjustments to maximize clinical outcomes. And the important thing that we're really going to be focused on is this relationship between pulse amplitude and electric field strength. This is the segue into our clinical trial. We completed this last year, and we randomized people to 6, 7, and 800 milliamps prior to starting ECT. The reason we did not go down to 500 milliamps was because our preliminary data suggested that nobody was responding to 500 milliamps. So we specifically avoided the lowest of the low amplitudes and just randomized folks into the 6, 7, and 800 groups. This is all in an older patient population, 50 to 80 years of age. I'm a geriatric psychiatrist, and ECT is recognized as a treatment specifically for late life depression, although the indications are crosses the life spectrum. Dr. Sauer just had a successful completion of a 10-year-old with a dramatic response and complete remission. So it does cross the lifespan, but the focus on a kind of a classic ECT recipient is about 65 years of age. The randomization, we were shooting for 30 subjects in each group. We set up a bitemporal contingency at the second or midpoint assessment. We did assessments pre, mid, and end of ECT. The midpoint assessment was always after the 6th ECT treatment, and so it was a fixed number. And the last or third post-ECT visit was variable. Whenever we determined clinically that was the end of ECT, that's when we would get the last visit. If the subject was not making adequate progress by the midpoint, they would transition to a bitemporal electrode placement. And this is from a human subject's protection. We want to make sure that participation in our studies does not jeopardize somebody's response to ECT. So we put that safeguard in and tracked the data accordingly. We still received neuropsych and imaging at the very end of the assessment. The results from a antidepressant perspective were interesting. We did see that the higher amplitudes were associated with improved antidepressant response. The 600 milliamp had a very unusual pattern. I just want to emphasize the red line, which is the summary. This is the pre, mid, and post-ECT trajectories. Once typically we see folks starting to respond to ECT, it's essentially typically linear. And this is really illustrated in this 700 milliamp arm, where it's just a question of completing a sufficient number of treatments to get people to continue to improve after the 6th treatment and end of ECT. So that's pretty typical. Interestingly, in the 600 milliamp arm, we had many subjects that initially showed this improvement, and then in the second half of ECT actually worsened and had more depression severity, sometimes back to their pre-treatment baseline. This was a really concerning trend and something we are not used to seeing on the ECT service. But the end result was that the 600 milliamp arm was ineffective as far as our usual ECT response rates, and differentiated themselves from the 7 and 800 milliamp arms. Again, the 800 milliamp arm is our active comparator arm. We did do a change in pulse width towards the tail end of this investigation. This was with great deliberation, IRB approval, and NIMH approval. And the idea was to see if we could change this trajectory with a longer pulse width. The idea is that decreased pulse widths may decreased amplitudes may need a longer pulse width from a strength duration curve. And that essentially was ineffective. And that's illustrated by the green dots here really did not really impact our outcomes at all. So the end result was 600 milliamp is relatively ineffective, and the enthusiasm for doing low amplitude ECT is pretty minimal, having watched these subjects fail to respond. And it took a lot of encouragement from Dr. Davin-Quinn in order to complete the study. I wasn't blinded, I was aware of the outcomes. All the assessments were done by Megan Lloyd, is our main research scientist involved with the study. She was blinded to amplitude arm. And she was not aware of this, but it really dampened my enthusiasm for the low amplitude outcomes. Our focus, of course, is on the hippocampus. And consistent with our neuropsychological input, this is Dr. Sean McClintock, University of Texas at Southwestern. He's an ECT cognition expert. We selected as our primary cognitive outcome the percent recovery for the Hopkins verbal learning trial, and it was the best we could do, a hippocampal dependent memory function that we could easily get pre, mid, and post ECT. The results did not show any relationship. It's essentially equivalent across all arms, and this is only specific for right unilateral ECT. We did fortunately do a more extensive neuropsychological battery. And what we did see was Fluency demonstrating the opposite pattern. Again, antidepressant response is higher amplitudes are better. It was the exact opposite when we look at cognitive outcomes. This is the DeKeff Verbal Fluency Scaled Score. This is essentially unchanged in the lower amplitude group. And you can see these dips happening between pre and mid for the 7 and kind of a larger dip for the 800 milliamp arm between the pre and midpoint assessments. Again, this is very specific for right unilateral. We also saw this with category fluency as well. And when you put all our neuropsychological tests together, we did see a disassociation on type of test. All of the Hopkins, no matter what construct we used, was poorly sensitive for amplitude mediated differences. But Fluency was also very sensitive. The surprise a little bit came from dot counting, which we were initially including as a control. It's a very easy to administer test. And we're going to suss these results out a little bit further. It might be a very useful and easy screening tool for early ECT cognitive impairment detection. But there were some specificity based on the type of neuropsychological test. The other aspect is autobiographical memory. We're still looking at that. That's a very hot topic where they do show some deficits in autobiographical memory up to 6 months post-ECT. And we did a very good neuropsychological test, the autobiographical memory test from a psychometric perspective, and we're still analyzing those results. The initial analysis didn't really demonstrate any changes, but the results have yet to be finalized at this point. But we really want to go beyond pulse amplitude. If you were to take those results, one could interpret our amplitude clinical trial and this trade-off between antidepressant efficacy and cognitive risk and just say, hey, everybody should get 700 milliamp ECT. That's not what we're recommending. We're not recommending that because there's tremendous variability regarding the electrokinetics. And there's this relationship between pulse amplitude, electric field strength, then we're looking at the electric field strength to neuroplasticity to clinical outcomes, both the antidepressant as well as the cognitive impairment. This is what electric field modeling looks like. We do this based on the pre-ECT imaging data, and we get a T1 and a T2 MRI. We do tissue segmentation, skin, skull, cerebral spinal fluid, gray, white matter. Then we mesh the ECT stimulation. It's a 5 centimeter diameter, and this is mimicking right unilateral placement. And then we use finite element solver to create the electric field strength throughout the entire brain. This is technically a vector where it has direction. We are just looking at the construct of electric field strength, which is a scalar quantity. And essentially, every MRI voxel has an assigned electric field strength. The data that I'm going to be discussing with you is essentially by anatomic region, and we're going to be looking at 95th percentiles of electric field strength. We don't want to look at the maximal because of boundary effects, and it can be very misleading. So the 95th percentile removes the effect of these boundary conditions and allows us to look at, say, a hippocampal electric field strength relative to amygdala and so forth. The anatomic variability is illustrated right here, and this is from our colleague, Dr. Z.D. Dang from National Institute of Mental Health. And this is based on spherical head models. Again, the spherical head models have the same tissue types and established conductivity patterns with each conductivity type. But I really want to emphasize the impact of brain volume. On the y-axis, we have the activated brain voxels relative to all brain voxels. So it's a percent of stimulation. The 0 here on the x-axis is essentially no brain change. But really common in late life is to have folks with maybe 5 or a 10% volume reduction. And you can see how this would impact the percent stimulated. If you have a 10% smaller brain than somebody who's, say, 20 years of age, you're essentially going to get 20% less brain stimulation. And so this is just one of many neuroanatomic variables that really illustrates some of the variability and disassociation between what we put on outside the skull and what the brain receives from that extracranial dose. Head diameter is important, scalp thickness, scalp conductivity, and skull conductivity all contribute, and is really specific for the right unilateral electrode placement. These are our results from doing e-field modeling on our subjects that completed our clinical trials. The result was the focus of our clinical trial was really to augment the electric field variability between 6, 7, and 800 milliamps. The clinical trial results were a little bit of a secondary goal. And you can see that it was successful in augmenting this variability. This is our right hippocampus. On the y-axis, you have the E-field of the right hippocampus, or in the orange boxes, orange slopes and dots are the left hippocampus. So I'm really just going to focus on the green. And you can see how with each amplitude arm, you get about a 10 volt per meter jump in electric field strength. But there's tremendous variability between each amplitude arm, such that subjects in the 800 milliamp arm had the exact same electric field strength as the 600 milliamp arm. So essentially crossing over. We have subsequently redone this analysis. And again, this is based on pre-ECT data. And if everybody was assigned to 800 milliamps, kind of our active comparator arm, we would see essentially the same amount of variability that we see right here. So the rationale for augmenting with the different amplitudes was actually unnecessary. There's enough variability just with a standard amplitude to see this, this range independent of assigning people to different amplitudes. This is an analysis that we did with the Global ECT MRI Collaboration. This is 150 subjects that received right unilateral ECT. And the question is, does E-field associate itself with neuroplasticity? And this plot contains both right and left hemisphere data. This is our right hippocampus in blue, and the left hippocampus is right here in orange. The slope on the left hippocampus in this example, where subjects were receiving 8 and 900 milliamp, is associated with volume change. And this survived multiple comparison correction. We looked at all brain regions, left and right hemisphere. And so it was a very rigorous correction that essentially it was both the left amygdala and left hippocampus. The reason that the right hippocampus didn't really demonstrate this relationship, we believe, is that it hit a bit of a ceiling effect. When you look at the y-axis, your percent volume change, we're up to 2.5, it goes up to 7.5%. So you can only do so much volume change, and you essentially max out this relationship. But when you really start looking at lower E-fields, then you see this linear relationship. And the data that I'm introducing next is essentially at a lower amplitude. So we're going to shift from the focus of the left hippocampus, we're going to go to the right hippocampus. And this is our relationship from our clinical trial. And we are including the bitemporal electrode placements. The effective time on hippocampal neuroplasticity is important. And to not include people who switch to bitemporal would be a major miss. And so essentially, once you put the framework in motion for hippocampal neuroplasticity and try and control as best you can the effective time, we see a very nice relationship between the E field in the right hippocampus, this is in volts per meter, and the percent change in the right hippocampus. Higher E field, more neuroplasticity. And this was specific for the right hippocampus. We actually looked in the left hippocampus, the relationship was not evident. We did the right precentral gyrus, which has a very high E field that did not demonstrate this relationship. When we looked at the direct effect of the E field in the right hippocampus, and is this related to change in depression outcomes? These two things are not related. However, the neuroplasticity or relationship with the degree of change in the hippocampus relative to antidepressant outcomes is highly significant. It's essentially the more neuroplasticity, the greater the antidepressant benefit. And this was illustrated when we did structural equation modeling. We're trying to kind of better understand this relationship. And so the E is the E field, and again, no direct relationship to antidepressant. When we look at the effect of a mediation variable with this change in hippocampal volume, you see this very nice relationship where it goes E field change in volume to antidepressant outcomes. So we're not going to look in cognition at that percent recall or memory function, since we already know from our clinical trial results that verbal fluency is the most sensitive to these outcomes. We're going to really focus just on that change in letter fluency. And we see the relationship evident directly with E field. More E field in the right hippocampus does impact change in verbal fluency. A normal verbal fluency range from a 4-week pre-post perspective would be about a range of a -3 on scaled score. So anything below that is consistent with impairment. And you can see kind of a real concerning trend where a lot of our folks were really impaired on verbal fluency. Consistent with the frontal temporal dependent function of verbal fluency, and we're specifically talking about letter fluency, the results were less strong with category fluency. We do see a nice we don't see the same relationship with hippocampal volume change. This was not significant when we looked at volume change as it relates to letter fluency. And this is consistent with our structural equation modeling, it's the same construct, but we saw a direct relationship between E field and change in letter fluency, that the change in hippocampal neuroplasticity was not a mediator. This direct relationship between E field and letter fluency did allow us to do receiver operator characteristic curves. And what we determined is this optimal trade-off at essentially 112 volts per meter in the right hippocampus is essentially the upper threshold for optimal dosing for ECT. It had a pretty robust area under the curve of 0.78. And if we couple this result with the association that higher is better from an antidepressant perspective, putting in that hippocampal neuroplasticity mediator, this gives us the upper limit of what higher is better really means. Clearly, we just don't want to go maximal as we can. We want to kind of find this trade-off where we can do the maximal E field in the right hippocampus up to a certain point. And that certain point is 112 volts per meter based on this data. And what we're trying to do is essentially revisit how ECT is done. If we really know where and how much the electric field should be within the brain, right hippocampus, 112 volts per meter, we can reverse engineer and do this pre-treatment with E-field modeling to determine what the individualized amplitude should be. So somebody might need, say, 500 milliamps to achieve this 112 volts per meter. Another subject might need 1200 milliamps. We don't know, but we can determine this. We do have the tools to do this. And this is illustrating the results of our clinical trial and just this almost shotgun approach. Whatever we put in, whether it's 800 milliamp or 600 milliamps, we don't know what the brain's going to be receiving. And this is essentially how we do ECT, specifically this 800 milliamp. So it's a paradigm shift from fixed input outside the skull to variable output inside the skull to a variable input with an optimal output or a very consistent dose inside the brain. And the way to achieve that is through E-field modeling. I'm going to introduce one other thing, but before we shift to how to do this, I do want to emphasize Dr. Miller's work. And this is incorporating the seizure, which we really haven't focused on too much in this presentation, but essentially the relationship between this E-field dose and seizure. Specifically, this is done with ictal power. And we looked at all sorts of frequency domains. And this is with a 24-channel EEG acquisition, so wireless acquisition. This is Lee Paul. He's our ECT nurse. He's modeling the kind of the World War II fighter cap here. And we cut holes in this $900 cap as soon as we got it in order to do the ECT stimulation handles in the cap. And this allowed us to look at 24 channels. Our focus that I'm going to be presenting is based on FP1, FP2. These are the forehead channels that we use for routine monitoring of ECT. And instead of looking at the electric field of the hippocampus, we're going to be looking at the electric field of the brain. This is again measured in volts per meter. It's the same construct though, and they're tightly related. The electric field of the hippocampus has a relationship with the E field of the brain at about a 0.92, so very tight relationship. But here you see this relationship as we go up with E-brain or up with the essentially electric field dose. We see that the ictal theta power, during the seizure, the theta power actually increases. And it's a very nice relationship evident in both FP1 and FP2. And we will look at all the different channels. We see about 70% of the channels that demonstrated this relationship. So it is really a whole brain phenomenon where the higher the E field dose, the more of this ictal theta power matters. The translational impact of ictal theta power is the relationship that ictal theta power is also related to letter fluency. We had one anomalous subject here, but this is the relationship. We looked a little bit better in FP2, but it's this really nice relationship that the worst cognitive outcome on your y-axis is indicative of increased ictal theta power. And you see a little bit of a lateralization effect here on the right hemisphere. But again, it's essentially, we're interpreting this as kind of a whole brain phenomenon at this point that transcends FP1 and FP2. And this investigation is now, Dr. Miller is incorporating near-infrared spectroscopy to kind of further suss out this relationship. So exciting things in the pipeline for sure. So we already mentioned the E-field informed ECT as one solution to this problem. The other solution to this problem is amplitude titration. And so I've already discussed the way we determine seizure threshold is by pulse number. But if we were to flip that algorithm, essentially keep pulse number a constant and increase the amplitude until the patient has a seizure, that would be another way to kind of have less variability in the E-field dose. And this is a study, this is done from, Lee is the first author. This is Dr. Holly Lisenby's group. These are 4 non-human primates. And they did amplitude determined seizure threshold. And this is E-field with right unilateral ECT with these 4 non-human primates. And if we just focus on the similarities, they do look very identical on the E-field. Again, the red is a higher thresholded with relative to neuronal threshold for firing. Red is definitely going to be way above that neuronal threshold for firing. But then we get into this variable input. This was 107 milliamps, and this was 284, so almost a 3-fold variability in amplitude necessary to get that consistent dose. And this is the right unilateral data. This is with amplitude titration. The y-axis is the percent variability among subjects. And this is the amplitude titration, very low, about 20%, 30% variability. And we get up to almost 60% variability if we were to do traditional fixed amplitude titrations. The issue, though, with amplitude titration is that it's very low. We're going to introduce that low amplitude ECT again. And so, yes, we can control for the dose and have a consistent amount of brain stimulation, but in my opinion, this will not be clinically effective ECT. And that gets us to the study that we're doing right now. We are trying to essentially find that relationship between amplitude seizure titration and clinically effective ECT. The historic data suggests that amplitude titrations can go as low as 233 milliamps. And I've already talked about the amplitude range on the standard MECTA ECT device allows us to go down to 500. And our clinical experience plus other investigators clearly demonstrate that 500 is clearly achievable to achieve a seizure. The issue is you can't do method of limits if you start at 500. You can't determine what the minimal amplitude necessary to induce a seizure is. So in partnering with Soterix Medical, they came up with an amplitude reducer. And this device is, so the output, it comes from the MECTA, and it's required in FDA investigational device exemption. But the power generated goes through this Soterix device and actually drops the current down to 200 milliamps. It even drops it below that, about to maybe 160 milliamps, and allows us to increase the amplitude in 40 milliamp increments until the subject has a seizure. And we're measuring the output with the oscilloscope right here. And so it's quite an elaborate process to determine this amplitude determines seizure threshold. But what we are determining is that the amplitude range is robust. These are our subjects to date. We have 14 subjects that have completed the protocol. And we see an amplitude that went to a historic low of 189 milliamps, exceedingly low. But I really want everybody to kind of focus on the range. We go from 189 milliamps to 686 milliamps. So almost a fourfold range. We talked about the non-human primates having about a threefold range. This is like a 3.5-fold range. So despite this amplitude determined seizure variability, we still give everybody 800 milliamps. And that relationship between this amplitude determined seizure threshold and how the brain changes at 800 milliamps is the crux of our hypothesis. If you can intuitively think about what subject is going to have the most hippocampal neuroplasticity, is it can be the subject close to 200 or the subject close to 700 if they then go to 800 milliamp. Clearly the subject getting 200 milliamp seizure threshold is going to have a lot of hippocampal neuroplasticity when they get the dose at 800 milliamp. And that is what we're using to get to our amplitude multiplier that we're going to try and bridge the gap with from amplitude titration to clinically effective ECT. We're speculating it's probably going to be about a 2.5 to a 3-fold multiplier. But unlike seizure titration by pulse number, and we do this 6 times threshold, we'll know why we're doing the 3-time multiplier. Is essentially because we need this electric field to be close to 112 volts per meter. And if that 3-fold multiplier allows us to do it, that's why. And that's our upper limit for antidepressant efficacy while maintaining cognitive safety. And so that's the current project that we're working on right now. I just want to conclude a little bit with some recent analysis that we did with some very talented data analytic investigator. They have background in mathematics, computer scientists, and to date, the data I presented you has been very focused on one specific brain region. And this is really based on a lot of the ECT imaging literature, all suggests that the hippocampus is really the region of interest to focus on based on neuroplasticity. But what if we cast the net wider and we look at the entire brain? And it's a very complex organism. But if we did a data-driven approach where we did not select a region ahead of time and we let the data dictate what regions and what patterns were essential for looking at both antidepressant response as well as cognitive impairment. And this is Dr. Key she's Georgia State right now, works with Vince Calhoun's lab. And also her mentor is Dr. Jing Sui. We have a long history of collaborating together on these kind of really sophisticated analytic strategies. And this is a fusion analysis where we combine functional MRI with structural MRI. The functional MRI is this construct called fractional amplitude of low frequency fluctuations. It's essentially looking at the low frequency oscillations evident in resting state fMRI, but it does it at the voxel level, which really helps us kind of determine with the degree of specificity where in the brain it's important. The gray matter changes are done with voxel-based morphometry, which is essentially a metric for gray matter density. So she essentially takes all of the voxels and concatenates the data. And then based on the degree of change in antidepressant networks for one analysis, and the second analysis was based on the change in verbal fluency, selects networks that best explain these both antidepressant and cognitive outcomes. The next thing we did is compare the E-field strength within these networks. The emphasis here is the degree of overlap between our antidepressant, as well as our cognitive networks. The other aspect that's really interesting is that despite not selecting the hippocampus does show up in both of these networks. So the first one is the ECT antidepressant network, which is it's rarely specific for decreased FELF, which again, you can maybe interpret this as a diminished functional connectivity, but FELF is really a very unique and specific metric. So I hesitate from kind of calling it a change in connectivity, but it's essentially a drop in this low frequency fluctuation. And it's specific to the prefrontal cortex and the caudate. This all decreased. There was no increase in this relationship. From a gray matter density perspective, it was all associated with increased gray matter density in the thalamus, hippocampal complex, and medial temporal cortex. For the cognitive impairment networks, we're again seeing the prefrontal cortex, you again see the caudate, but you see the hippocampal complex show up in the functional networks, and the gray matter is temporal cortex and the putamen. But the overlap, and the reason the overlap is important is when we think about parameter develop, one idea is to think about affecting essentially where we place those ECT handles and maybe using an array as opposed to just 2 stimulation handles to have a more focal form of ECT. This is what focal electrical administered seizure therapy is trying to do, essentially enhance that specificity of where in the brain we're stimulating. But these results really suggest that the antidepressant and response network and cognitive impairment networks overlap, and they do so in a way that's very consistent with our previously collected data in the context of E-field. When we look at E-field within this functional network and also the structural network, and we look at it from an antidepressant response perspective, we see the same relationship that higher is better. Consistent with our hippocampal results, if we look at the direct relationship between E-field within these functional and structural networks and antidepressant outcomes, it's very weak, area under the curve about 0.6. So it really suggests from an antidepressant perspective, even looking at other imaging modalities, we really need to put in the equation the effect that's having on the brain. From a cognitive impairment perspective, we do see a very strong relationship. Again, same pattern, increased electric field strength is associated with worse cognitive outcomes. But in very similar to our hippocampal data, we see a very strong relationship when we look directly at the change in electric field and how this relates to our optimal outcome. And we already mentioned the 112.5 volts per meter in the hippocampus. The data suggests that's 114 in the structure function network. So the result is not specific necessarily to just looking at the hippocampus, but with divergent analysis methods, we're seeing some synergy with the data. And we're hoping to replicate this with a larger study, multi-site study. The actual application goes in on Monday, but we're looking at this with hopefully 230 subjects. So that will be in the pipeline, hopefully within the next year. This is what our ECT service looks like. We're really fortunate to have a clinical staff that really supports our research. And this is our ECT device right here. We are doing a motor titration with the digitimer right here in this particular subject. This is Lee Paul, our ECT nurse. This is Dr. Miller. He is collecting and digitizing the EEG for later quantitative EEG analysis. This is Crystal Garcia. She is collecting NIRS, near-infrared spectroscopy data on the same subject, all done simultaneously. So it's a very rich clinical research service, and we're very proud of that. Our gratitude goes to our patients, though. We have majority of patients that are eligible for our study. We only discuss ECT research after they've met the indication for ECT. We've had that discussion, and then we bring up participation in our research. And we have an overwhelming percentage of subjects that are willing to do that. This research would not be possible without their participation. I just really appreciate the work with Dr. Quinn. He's been one of our longest collaborators. Dr. Earhart, our statistician, Dr. Zidi Deng from NIMH. We already mentioned Dr. McClintock from UT Southwestern, Dr. Argelin, we collaborated on the Geriatric study, and Dr. Ryman from Mind Research. Dr. Tom Jones is our data analyst, and Joel Upston, and Megan is our research scientist, and hats off to our ECT service. And that's my presentation. Any questions? Hey, Juan.
Hey, hi, Chris. That was just a tremendous presentation. I mean, really, really exciting data. And just a general question. I mean, I think if I understood, you presented so much data, but I mean, if I understood, I think it's really remarkable how you've been able to link the cognitive deficits to the E-field dose, and to the theta power. Is that right?
That's correct. Yes.
And be able to sort of separate that from the hippocampal plasticity, which seems to mediate the antidepressant effect.
Exactly.
And I mean, so I think that is tremendous. But I was wondering if you could speculate a little bit. You know, I've over the years, of course, I've read about how critical hippocampal plasticity is for antidepressant effects. But, you know, we don't typically think of the hippocampus as a region that functionally is related to emotion and affect, but more, of course, to memory. So, I mean, I was just wondering whether you can care to speculate about that. Is it that you just can detect it in the hippocampus because it's a region that is more sensitive in terms of plasticity in general for the brain, but it's just like the tip of the iceberg of some other circuit that is maybe more specific to affect regulation?
A really great question. And also, before I go any further, I'd be remiss not to acknowledge the decade of mentorship from Dr. Bustillo as part of my acknowledgements. We've had many, many lunchtime conversations about this topic. So it really gratitude to you, Juan. Thank you. Yeah, so I think it's a great question because the way I interpret this is that the hippocampus registers the effect of the ECT dose. You're right. We don't think about the hippocampus as we don't do deep brain stimulation in the hippocampus. We do that in the subcolossal cingulate gyrus. TMS is based on this relationship from DLPFC to subcolossal cingulate gyrus. And why are we looking at the hippocampus? And so it's related to that the data that I put up from the global ECT MRI collaboration, it registers the effect of the dose. When we look at the entire brain, that's the one that really demonstrates this relationship. And I do think it's related to kind of this intrinsic property the hippocampus has to be highly responsive to the E-field dose. And that's why it makes sense to really focus on the hippocampus from a dose perspective. It's not necessarily stimulating the hippocampus that we're after. It's stimulating the hippocampus at that intensity with this right unilateral geometry. Because if we control for the geometry, again, this transcends the hippocampus, gets into frontal networks, striatal networks, and so forth, then we know that we're doing adequate dosing to better do what we need to do from an antidepressant network perspective. So that would be the way I would interpret the focus, and sometimes rather myopically. And so I was really deliberate in putting this kind of whole brain analysis up to show, yeah, the hippocampus is there, but it really transcends the hippocampus.
Great. Thanks.
Chris, this is Kathy Holland.
Hey, Kathy.
Sorry, I don't have the video on, but I have a question about, as you can appreciate, the cognitive side of things. I'm really not familiar with the time frame of the cognitive changes that one sees after ECT. Is it chronic, or does it decrease and disappear after a certain amount of time?
So the cognitive impairment, if it does happen, doesn't always happen. If it does happen, we see a lot of variability as far as the recovery. The Simkowska meta-analysis that I put up initially has about a 2-week time frame that they're kind of expect the major resolution of ECT-mediated cognitive impairment should happen. However, we've seen a lot of variability. The subject that I mentioned, it was 3 months out was her recovery when she finally felt she was back to her pre-ECT baseline. That's maybe a little bit of an anomaly. My point in bringing that up is there's this huge range, and it is the recovery time is often related to the severity of the cognitive impairment. But then when we look at the specificity of the type of cognitive impairment and the autobiographical memory, there is some evidence that there may be some deficits 6 months out. When interpreting that data, though, it's important to recognize the instrument is somewhat controversial as far as what they are assessing. Is it really autobiographical memory? Is it more declarative memory? So there's a lot of controversies to that 6-month problem with autobiographical memory after ECT, and it's a work in progress at this point. But to succinctly answer your question, I would say weeks with occasional months recovery.
And if a person gets repeat ECTs, is it worse, better, or the same?
Yeah, so a lot of our algorithm at this point for an ECT responder is to really work on the durability of the response, and at a minimum do 4 weekly treatments prior to stopping scheduled treatments. Those 4 weekly treatments might prolong recovery times. We often hear about that. Yeah, I'm getting better, but then when we stop, we see a dramatic improvement as soon as ECT stops. Some people have poor durability of response and then need to come back for additional rescue series. And those are the ones we are most concerned about with cognitive risk.
Okay. Thank you.
Sure.
It's helpful.
Hi, Dr. Abbott. This is Dr. Delmore. I'm wondering if you can comment on the emergence of magnetic seizure therapy and its relative importance as compared to ECT and its effect on cognitive side effects.
Good question. So our colleague, Dr. Sean McClintock, UT Southwestern, they're actually conducting a multi-site ECT versus MST study. Results are, they're not able to access the results, I think, for another 3 years. And so they're still in the blinded phase of the study for all researchers. Magnetic seizure therapy is very interesting. We're actually putting the data for MST into our next grant submission as a potential as a contrast from Dr. McClintock's data. And the idea is to disentangle the effective E field. The magnetic seizure therapy is going to have a very small E field, very low intensity, and consistent with that, there's a lot of evidence that it's going to be have more cognitive safety associated with MST relative to ECT. What we don't know is if it's going to be comparable with respect to efficacy. So that remains to be determined. But if it is, it's going to be a very promising new neuromodulation technique. All right, shall we adjourn? All right, goodbye, everybody.